Good morning. It's a real honor and pleasure to be here. Thank you, Dr. Nahida. Thank you, Dr. Samir, for organizing this conference. I also want to thank Kim and his team for all their hard work. It's actually quite complicated these days with COVID, with travel and everything. So thank you for making this happen. Thank you, Dr. Khalid, for the introduction. Always good to see you, and Dr. Fadi Malouf, who we trained together many years ago. So it's always lovely to be here. So I'm going to start with disclosures. I really don't have much to disclose in terms of conflicts of interest. I do receive funding from federal funding in the US, and I've received funding from the World Health Organization and some other foundations, but I do not have any other relationships to disclose. Our topic for today is ADHD in focus. Being here for me is also very personal for a few reasons. I'll show you those reasons. This was, sorry, I'm kind of dating myself here, but this was in Al Ain. I was actually, I did high school here in Al Ain in the UAE, so being back here is very personal for me. But it's also very personal for me for another reason, because this is Boston a few days ago, but actually today there's a blizzard. There's snow, like 2 feet of snow. So, you know, waking up today and kind of seeing the sun and the beauty of Abu Dhabi is very special. So again, very happy to be here. So this is the outline of my presentation. I will talk a little bit, maybe provocatively, does ADHD exist? What causes it? I'll talk a little bit about ADHD over the lifespan and the types of impairments that ADHD can cause at different ages. I'll talk briefly about diagnostic criteria, comorbidities, medication management, and other interventions for ADHD. I'll try to be disciplined. I can't promise to be as disciplined as Dr. Fadi with the time. I have a lot of slides, but I think some of the medication slides I'll go through a little bit quickly because I know not all of the medications are available here, so it might be a little bit less relevant. So does ADHD exist? So you'll see this cartoon. You'll have to excuse George. He suffers from perfectly normal child disorder, right? So, you know, children are active. When is it too much activity? Children could be distracted or not always focused. When does that cross kind of that boundary to become a problem? So speaking to this audience, I hope this is less of a question. Does ADHD exist? Yes, it definitely exists. I think there's a lot of evidence at this point. All types of evidence. There's genetic evidence, there's neuroimaging evidence, there's pretty consistent epidemiological evidence from all around the world. So there's evidence from genetics, very high heritability, about 75%. And we see this clinically all the time. You got, you know, parents bringing their child who maybe is identified by teacher for a diagnosis. And I can't tell you how many times this happens that eventually, you know, after getting to know the family, the parents tell me, well, we're getting tested ourselves for ADHD. We noticed that we actually share many of the symptoms. And so the heritability is very high. Genomic wide studies have also confirmed that. But there's also a lot of imaging studies. Our group has done some imaging studies in this area, but there's very consistent kind of structural findings, different areas of the brain, smaller volumes in the dorsolateral prefrontal cortex, the caudate, the pallidum, and the corpus callosum. There's a bunch of functional studies, SPECT scans, PET scans, EEG findings as well, although not always as consistent. And then epidemiological studies, prevalence, you know, there's obviously different estimates depending on where you look, but generally we say about maybe, you know, 8 to 10%, I think is pretty consistent. And this is, again, more or less across nations. Not a lot of epidemiological studies from the region, but there's some from Saudi Arabia. I believe there's also one I saw from the UAE from Dr. Epen about 10, 15 years ago. And it affects people in all social classes. It's across social classes and across regions. So ADHD is one of those things that has gone through a lot of different names over the years. There's literature going back to the 1800s describing some of the descriptions. Some of them were actually not very pleasant. I'll show you some, but pretty much still who was a pediatrician in the early 1900s did kind of a good description in the Lancet. And then there's kind of different names that evolved over the years, moral control. And again, when you think about stigma, some of the stigma, I think, comes from this, right? Kind of our earlier understanding of many mental illnesses. So this was a problem of moral control at some point. Autism was a problem of the refrigerator mother, right? Did you hear that term? So some of the stigma actually comes from the very early poor understandings of some of these illnesses. Then the understanding started to evolve, minimal brain dysfunction, at least it's an understanding that's a brain dysfunction. And then there was this incidental finding not too far from where I practice in Boston. This was Bradley Hospital, 1937, I believe. And it was basically someone kind of trying a medication called Benzedrine for headaches for a group of kids at Bradley Hospital. So there's a lot of developmental disabilities, sure ADHD. And they noticed, although they were treating them for headaches, that these kids started doing better with things like focus and academic functioning. So it was incidental finding, but a very important one. And then, you start seeing kind of some of the more standard names that we see now: hyperactive child syndrome, hyperkinetic disorder, ADHD, ADD plus the H. What we have now, we call ADHD in general, and then predominantly inattentive or predominantly combined. But even back in the 1800s, Heinrich Hoffmann, I believe a German psychiatrist, described impulsive insanity and defective inhibition. I mean, just look at these names: impulsive insanity. So yeah, and this was kind of the original kind of article by George Still in the Lancet in 1902. So what happens with ADHD? So there's a lot of impairments that come with ADHD, and some of them may come at kind of different phases of life. But you start off a lot of times very early on seeing some of these academic limitations. My son is very smart, but they don't do well in school. Why is that? My son is very smart, but they can never sit in their seat. They can never get through a class. Then you see impaired family and peer relationships. So this child now becomes impulsive, disruptive, starting having tension at home, tension in school. And then usually kind of as preteens or early teenagers, they start realizing how much of this is a problem for them and for other people around them. They start feeling bad about themselves, right? I mean, if you're 6 years old and you're always getting called upon by the teacher for not listening, you go home, your parents scream at you because you're not doing well, it starts sinking in. You start feeling bad about yourself, and it becomes a big risk factor for depression, right? Injuries, many times, you see these kids who are literally in the emergency room every few weeks. They break a bone, they fall, they're jumping, whatnot. So you see a lot of injuries. And then smoking and substance abuse, and we'll talk about this later, because people have the tendency to self-medicate. If you're not going to treat their problems, they're going to want to find their own solutions for the problems. Motor vehicle accidents when they start driving, and then all types of occupational, vocational, and potentially legal problems. So this sounds very dismal, but actually there's some good news. I mean, it's one of those disorders where when people talk to me about prognosis, it's mixed. So it is a chronic illness, it's a neurodevelopmental illness. However, there is some good news. So if you see here, and I hope this is clear. I know some of the curves look very similar, but let's start with the impulsivity, kind of the straight line. So you see impulsivity generally going down, and then kind of around puberty, because this is an age of more impulsivity, goes up, and then kind of starts going down again. And then the one that I think there's the best news here is the hyperactivity, right? So it's consistently going down. So, and again, from clinical experience, if you follow these kids for a period of time, they're not as hyperactive at the age of 12 as they were at the age of 6, and certainly at the age of 20, they're not as hyperactive as they were at the age of 6. But again, it doesn't go away. It might be more of a feeling of restlessness as opposed to like this kind of bouncing off the walls that some people describe. But some of the symptoms do get better with age. And in terms of diagnostic criteria, 60% still exhibit symptoms into adulthood. So there's 40% that may not kind of strictly follow diagnostic criteria. It doesn't mean it's completely gone. I think that's important. You might still find some degree of impairment. But if you're thinking strictly about DSM and meeting with criteria, you know, some people kind of like start not showing maybe as much symptoms, especially in the hyperactivity realm. So it's one of these disorders where there's a lot of different myths about it versus facts. So is it only a childhood disorder? Maybe this was an understanding 20, 30 years ago. We know it's a lifelong disorder. Applies only to boys. No, there's many girls who have it, but tend to have more of the inattention symptoms and may not get diagnosed. Is it a Western phenomena? No, it's certainly a worldwide, it has a worldwide prevalence. Is it a behavioral disorder, just kids misbehaving? It's not. It's a medical disorder that has behavioral manifestations. And it's also highly comorbid to some behavioral disorders like oppositional defiance disorder and conduct disorder, but it's not just kids who are not following rules or misbehaving. It reflects inadequate school funding. Maybe there's some truth to that, but irrespective of even being in school or not being in school, it still exists, and there's a pretty standard worldwide prevalence. The medical agenda is being pushed by drug companies. Surely drug companies are there to make money, but irrespective of drug companies, it's still a problem that exists. The biggest study done, the MTA study, which I'll share part of it with you, was NIMH funded, hopefully free of any industry influence. And there's, again, a lot of scientific data about it right now. I'm not gonna go through the diagnostic criteria because I know a lot of you are familiar with it, but maybe just a few things to point out about the DSM-5 diagnostic criteria. So you need at least 6 out of 9 in attention-related symptoms over a period of 6 months. But the things I wanted to highlight are more kind of in the second page, and then we'll do the hyperactivity, impulsivity. Also, you need 6 out of 9 or more. But look at criteria B. So these symptoms have to be present before the age of 12. And a lot of people, as Dr. Fadi mentioned, are at least in the West, are diagnosed pretty early. I think, you know, in clinics, kind of most of the people we see getting diagnosed for ADHD come, you know, kindergarten, maybe to 2nd or 3rd grade. They start school, teachers identify that they're having struggles. They ask the parents to have an evaluation. Maybe for cultural factors, I don't know if this is similar here. Maybe this can come up in the discussion. But I think this is very typical of what we see there. But the point is that it's a neurodevelopmental disorder. Please keep that in mind. If you get somebody for the first time at the age of 18 with new onset ADHD-like symptoms, you have to really think deep and hard whether it's truly ADHD. Now, there could be other factors. Sometimes it could be ADHD. It's just never been diagnosed. There are adults who get diagnosed for the first time, but you have to be able to show that the symptoms have existed before the age of 12. You really have to be able to do that. If you're not able to do that, think deep and hard about the differential. You know, Dr. Fadi mentioned anxiety as a differential, depression is a differential. There's a lot of studies now looking at traumatic brain injury and almost like secondary ADHD, right? Somebody whose cognitive functions have always been pretty much fine. They get into an accident and have a traumatic brain injury, and now they're presenting with ADHD-like symptoms. So, but ADHD itself is a neurodevelopmental disorder. Important to keep that in mind. And then you have to have impairment in several settings. Again, that's very important. If you have a child who's only hyperactive or only inattentive at home or in school, but not the other place, that does not make a lot of sense. You have to, again, think why that's the case. Is there something about that specific environment that causes that problem? Because if our understanding of it as a neurodevelopmental disorder affecting the brain, you don't have an on-off switch that you're going to switch when you go to school and you don't have the symptoms, or vice versa when you go home and don't have the symptoms. Now, you know, manifestation can be a little bit different. Sometimes you hear from parents like, oh, school complains more. We don't have as much complaints in school. But, you know, you have to make sense of that. You know, for example, if they say, well, the attention problem is more prominent in school, that might make sense because your demand for attention in a school setting with 20 other students is a little bit different than your demand for attention at home. Okay, but you have to have symptoms in multiple settings. And of course, the symptoms, like any kind of DSM diagnosis, have to cause impairment, right? Because if they don't cause impairment, then they may not reach the threshold of being a diagnosis. So you can specify if it's a combined presentation, which is generally the most common, or the predominantly inattentive type, which you see a little bit more in females, and then the hyperactive impulsive predominantly presentation, which is actually quite rare. So the combined is actually the most common. Of course, we all know that there are limitations to the DSM. And again, this could be a whole presentation by itself, so I'm not going to get into it. But, DSM is very categorical. What do you do with the person who comes with 5 symptoms, but not 6? Do they not have ADHD? What do you do, with some of these criteria? Because, humans are not made to follow textbooks, right? We're all different, we're all unique. So obviously you have to take everything with a grain of salt, but obviously also DSM is very important because we can all speak the same language when we're describing things. Developmental phase is not taken much into consideration. The symptoms might be a little bit different as a teenager than they were as a 6-year-old. And of course, DSM criteria can lag behind new research findings, but that's why the DSM is consistently updated. So in this conference, of course, we're talking kind of across disciplines, and I think it's very important for people in pediatrics and primary care to think about the differential. So the differential is pretty wide, but I'm going to cover some of the main things, and also we want to talk about maybe some pearls, clinical pointers to help us think about, what is causing, because when someone comes to me and say I have an attention problem, I say that's a little bit like having a headache, right? There's a long differential for having a headache. Headache could be many things, and the same for attention problems. So one is depression, but some of the differences is that the mood component, right? The irritability, the anger that it's, you would expect that much more depression, but also the episodic nature. So ADHD as a neurodevelopmental disorder is not episodic. Yes, it could look worse in certain environments or certain settings, but certainly not episodic, while depression and other mood disorders like bipolar are episodic. Anxiety, another also big differential. If think about times you were anxious or I was anxious, I'm sure I'd be distracted, right? So that might very much look like ADHD. But a lot of times I ask these kids, like, when you're daydreaming or when you're distracted, what's on your mind? Is it a worry? Because if you're anxious, it very much could be a worry. But if you are a child with ADHD, yes, sometimes it could be a worry, but you might be sitting in class and daydreaming about being on the beach, right? You're not worried at all, but you are distracted. So it's important to ask these questions. Again, depending on the age of the child, their ability, you might get clear or not so clear answers, but it just might help you make some of these distinctions as well. Besides, the age of onset, like Dr. Fadi mentioned, for anxiety, maybe it's a little bit later in life. So, if you have a 4 or 5-year-old coming to you, it's a little bit more likely that it's actually ADHD if they're distracted than maybe it is anxiety. Of course, it could still be anxiety, but try to ask about the quality of the distraction, like what actually gets them distracted. Oppositional defiance disorder and conduct disorders are highly comorbid. Some studies show up to like 50%, but it's not part and parcel of the diagnosis itself. ADHD is a different diagnosis than oppositional defiance disorder. And some of what you see with oppositional defiant disorders, like, being very defensive, being very angry, being very blaming, versus in ADHD, some of the misbehaviors might be more a result of impulsivity. But again, very highly comorbid in general. Learning disabilities is a very big part of the differential. Many of these kids have learning disabilities. I mean, in a way, you can think of ADHD itself as a learning disability of some sorts. I know this may not be as relevant here as I was just talking to Dr. Fadi earlier today about, in the US, for example, we don't get involved at all with the learning disabilities because it's primarily kind of a school function. People come to us already diagnosed with dyslexia, already diagnosed with a learning disability. So it's not something that we do as clinicians. Well, my understanding here in the Middle East is that schools may not have that capacity to do that testing, and it might be, again, up to kind of clinical folks to do this testing and make these diagnoses. But when people come to me, I ask if they already have a diagnosis, if they have a special education plan, have they been tested? Again, it could be clinically quite hard to make the distinction between, you cannot really diagnose a learning disorder in kind of an office setting. But, sometimes you do want to ask if they're having a hard time, is it because they're not focused, or is the work just hard for them, right? If it's just hard for them to get it, even if they are focused. So if it's that way, it might be more of a learning disorder. But again, these are pointers that sometimes might be helpful. Sometimes you ask these questions and you still are not really able to fully make that distinction, and you might need to send them for testing for learning disorders. So we said ADHD shares characteristics with many other disorders and very highly comorbid with conduct disorders, substance abuse, learning disorder, anxiety, 20 to 40%, according to some studies, Tourette's, tics. So these kids interestingly tend to have more tics, although the medicines also have been linked to tics. So very important to get a very good baseline history, and also about sleep. We'll cover that later, because we know the medicines cause sleep problems, but a lot of these kids have sleep problems independent of being in the medicine. If you do not get a good history from the beginning, you might find yourself confused. Is this a side effect of the medicine, or is this part of the problem? Mood disorders, highly comorbid, and of course, a lot of interpersonal, poor interpersonal skills and feeling demoralized. Obviously, there's cognitive deficits, speech and language impairments, developmental coordination, tic disorders, other medical and physical concerns, and of course, a lot of social problems that sometimes arise from this impulsivity. So intellectually, how do these kids do? There's not been a link with any intellectual disability per se and ADHD. So it's different, for example, with autism, that we know that about 75% of people with autism have intellectual disability. A lot of folks who have ADHD do not have intellectual disabilities. Their IQ might be completely normal. It's just a matter of applying their kind of skills into real life situations. And we see a lot of academic problems. I'll cover briefly this topic, but again, this could be a whole different presentation in itself. Some people are less familiar with this comorbidity between ADHD and epilepsy. So as we said, ADHD's prevalence in the general population is about 3, 7, 8, maybe 10%. Epilepsy's prevalence might be around 1%. Yet the American Academy of Pediatrics estimates the prevalence of ADHD in patients with epilepsy to be between 12 to 39%. So almost like 4 times higher, right? So there's a clear signal here. A lot of people who have epilepsy have ADHD symptoms. Now, the inattentive subtype is a little bit higher, about 24%. The combined is 11, while generally in a general ADHD population, the combined is more common. But there's clearly some signal here. The relationship is bidirectional in nature. So if you have ADHD symptoms, you're more likely to have epilepsy. And if you have epilepsy, you're more likely to have ADHD symptoms. In a retrospective study, an EEG was abnormal in 6.1% of children with ADHD, significantly higher than in healthy children when EEG was abnormal in 3.5%. So you see this link here. Another study, pathological EEG findings were found in 30.1% of a sample of 176 children with ADHD. Some of the mechanisms proposed for that, and again, it's a very big topic. I'm not going to do it justice with a few slides, but there's been several mechanisms of why this might be the case. One is the effect of anti-epileptic medications. Some of the side effects of anti-epileptic medications may look like ADHD, especially the inattentive subtype. But this doesn't fully explain it, because even if you're not on epilepsy medications, you are more likely to show ADHD symptoms. Effect of chronic seizures and subclinical epileptiform activity. I mean, what are seizures? I mean, ultimately, they are abnormal electrical firing in the brain, and ADHD is a brain disorder. So, there's something there. I mean, they're both brain disorders of some sort. There's some theories about adrenergic dysfunction, but I think the one that probably holds the most ground, that there's some common genetic deficit or an underlying neurodevelopmental vulnerability that for some people shows as epilepsy, some people shows as ADHD, and for many people shows something kind of in between or a combination of both. So we think there's a potential common genetic pathway, and these are some of the things that maybe studies that support that. Studies in children who show signs of ADHD prior to developing seizures. There's some animal models, and we did a small study that found that the rates of ADHD in mothers of children who had ADHD and epilepsy were elevated compared to expected rates in mothers of children who had ADHD but no epilepsy. So I'm going to move on to start talking about treatment. I know we're running out of time, so I'm going to try to keep it brief. But like any thing we treat, it's a partnership, it's a team. So you think about this partnership with the child, with the parents, risk benefit, like any other medical decision. I'll cover briefly some of the medications, other therapies, and school interventions. Just a reminder to always read published studies with a grain of salt. This is one of my favorite. I almost always in all my presentations in the US, I show this. Shawarma is my favorite food, so I'm very biased towards this study. But this is the effectiveness of shawarma preventing and treating major depressive disorder, results of an open-labeled randomized controlled trials. And I would have to say that shawarma is one of the best things to help with depression. The authors of the study, as you see, are Cristiano Ronaldo, Rooney, Messi. So, always be careful when you read published work. All right. So psychopharm interventions in ADHD are very important. And I would actually argue that I think there's very few conditions in childhood where first line is medication. Someone walks into your office, make a diagnosis, and you say, you need a medicine. ADHD is probably on top of that list. And I'll tell you why, but the initial psychopharmacological treatment should be a trial with an agent approved by the FDA for the treatment of ADHD. So what are FDA-approved treatments? There's multiple stimulants, and we'll talk a little bit about their mechanism of action. And then there's atomoxetine, which is a non-stimulant, Strattera. And then there's a bunch of off-label treatments, like some of the alpha agonists. Wellbutrin has some special kind of attention qualities to it, tricyclic antidepressants, and modafinil. Okay, so it's a bit of a busy slide, but generally, if you follow, and there's many, different algorithms or whatnot, but if you look at the Texas algorithm for children, it says if one stimulant trial fails, use a drug from alternative stimulant class. So basically, we have the methylphenidate types and we have the amphetamine types. So if you start with a methylphenidate, it does not work, go try an amphetamine or vice versa. Efficacious and very well tolerated is one of my favorite conditions for treating for many reasons, but one of those reasons is that medications really do work. And this is not just based on clinical experience, but it's really, if you look at effect size here, it has a pretty large effect size, 60 to 70% to respond favorably. The effect size is about 0.95 for long acting, 0.91 for short acting. And for Strattera, atomoxetine, the non-stimulant is about 0.62. But just to kind of put these numbers in context, so 0.9 is kind of around the, if you look at other models of medicine, kind of taking an inhaler for asthma, not being able to breathe, taking your inhaler and being able to breathe. So this is very high. And I think this is one of the very few conditions where, I could start someone on treatment, a week or two later, I get a call from the family saying something like, this is night and day. In treatment of depression with medication, treatment of anxiety with medication, literally treating anything else we treat with medications, you don't usually get this very kind of clear, strong, and relatively fast response. So these medicines do work very well, and they could be pretty life transforming. When are stimulants not considered first or second line? You'll find some controversy around this. For example, tic disorders, some people say don't try stimulants. Some people argue that actually stimulants do not make it worse. But anyways, there's some comorbid conditions where you might want to consider non-stimulants. So one is comorbid tic disorders, where you might want to try Strattera, or still try a stimulant and add like an alpha agonist, which has efficacy in tic disorders. Anxiety disorders, again, you might do the same. You might treat with a stimulant and an SSRI, or you might just go to a non-stimulant. Substance abuse disorders, you might want to treat with Strattera or long-acting stimulants. So this is kind of probably the gold standard study that has been done, the MTA, and until now they keep publishing follow-up studies after years and years and years. But this study almost looked at 600 children between the ages 7 and 10. It was a really nice design because it's basically looked at intense medical management, so medications, intense behavioral treatment, so with no medications, combinations, medical and behavioral treatment, and routine community care, which basically was whatever you were doing, keep doing, right? So 14 months later, they found that medications and behavior were better than all other forms of treatment. but also not a statistically significant, and just say it's not statistically significant difference between meds versus meds and behavior. That does not mean that behavioral therapy has no role. I think it just tells you how important medications are in the treatment of ADHD. Because again, you get a lot of parents and they say, okay, you made a diagnosis of ADHD, can I try other things? And I always say, of course you can try other things like behavioral therapy, but medications are very important, and this is the study to support that. Now, what about preschool children? There's the PAT study, 3 to 5.5 years old. They found that ADHD, that the medication still helped in a dose-dependent fashion, but the effect size was a little bit lower than school-age children, and rates of events were higher and different. How effective is methylphenidate? 70% of patients respond to the first stimulant, and about 90% by the time you try the second one. Mechanism of action, it blocks reuptake. So for the methylphenidate, we'll talk about the amphetamines. It blocks reuptake of dopamine via dopamine transporter, and the effective doses block at least 50% and above. So it increases dopamine and to some degree norepinephrine serotonin in the synaptic cleft. Again, I'm not going to spend too much on medications per se, just because I know not all of them are available here. But I think the take-home messages are that you have formulations that are immediate release, might work for like 3 to 4 hours, some that are longer release. A lot of the differences are nuanced. Like, for example, some mechanisms of the longer acting release may be like 50% immediate and 50% longer acting, or maybe 30 and 70. So a lot of the difference between them really are kind of in that sense, like how long they work, how much do they release early versus later. This is specifically Concerta, which I know is available here, and is one of the longer acting ones, works for about 10 to 12 hours. Probably about 25% kind of earlier release, and then 75% later. And then there's many like Metadate that are kind of biphasic, but about 30% earlier, and then 70% continuous release. And then a couple that are kind of 50-50, so 50% immediate release, 50% extended release. There's basically every few months there's new ones released, and they're still all generally kind of in the same methylphenidate or amphetamine groups, but again, just playing with some of the properties. Example, one just came out called Journey, like just maybe a year back, and it's actually a stimulant that is given at nighttime, which all stimulants are not given at nighttime, but it's extended release that by the time the child wakes up, it's already in their system, and that's just really trying to kind of work on this very big problem that these medicines take a little bit of time to work, but usually that time is with the kind of the immediate release, maybe it's 30 minutes, with the extended release maybe an hour, but that's the morning time when this kid is trying to get ready to go to school, put on their clothes, and the medicine hasn't kicked in, and it's a struggle. So this new medicine, apparently you give it at night and they're kind of ready at the moment they wake up. Some are patches. So there's really a lot of different options, but they all kind of are still in the same families of methylphenidates or amphetamines. Amphetamines attached to presynaptic receptors release dopamine, attached to synaptic vesicles release dopamine, so the increased level of dopamine. Again, there's some short acting and extended release. Adderall is a very famous one. It's about 50-50. Vyvanse is another one that's a prodrug. So if you remember from biochemistry, a prodrug is one that is inactive until it's kind of metabolized and becomes active. I know I'm kind of out of time, but maybe I'll try to very quickly wrap up with just a few things that are clinically very important, like issues related to growth, issues related to substance abuse, or the lack of, issues related to sleep with stimulants. So generally, in terms of, and this is, most of it was from also the MTA study, they reported 1 centimeter per year and 3-year follow-up up to 2 centimeters shorter and 2.7 kilograms lighter. So again, not a huge difference in terms of growth, but again, it depends on the phase. If you're starting someone at the age of 4 or 5, you might see more of that problem than if you're starting a teenager who's already achieved a lot of growth. And then there is a small group that have much more significant problems. And sometimes we do have to, alter the strategy or add even, nutritional supplements, or even add the medication to boost appetite. But for most people, it's not going to be very clinically significant. Adult data show subtle differences, typically normalized to expected adult size. but there is variability in literature. Sleep impairment is very important. Prevention is very important. Screen, as I said, for some reason, children who have ADHD tend to have more sleep problems regardless of medications. So it's important to be aware. Now, some stimulants, especially when you get to the longer acting ones, can have sleep problems as a side effect. So you want to kind of figure out how to deal with that, including with some medications at times. Risk of substance abuse and addiction stimulants. So non-medical use of stimulants has been dropping consistently since 2001. So basically, stimulant use in children will result in increased risk of substance abuse in the future. Is that true or false? This is also, again, quite a big topic in general, but the answer is it's actually not true. And in fact, not treating ADHD is one of the biggest risk factors for substance abuse. So that's a very important discussion to have with families, because that's legitimate concern that people bring to your attention. Obviously, there is a problem with diversion of some of these stimulants, because people who do not have ADHD might want to take stimulants for different reasons. I think it's very common, for example, in the US and college campuses, to have people who don't have ADHD who want to take an Adderall to stay up all night and study, right? So they don't have ADHD. But then you have people who have ADHD and then they're very concerned and they need these medicines, they're very concerned, they don't take them. So, you know, go figure. But it's very important to highlight that for someone not treating for being scared of having a substance abuse problem by treating, they're actually much more likely to have a substance abuse problem if they do not treat. And this is just some of the evidence. You know, we know we give these medicines like a lot of times just Monday to Friday on school days. They don't have any like withdrawals on the weekend or adverse outcome, and they don't develop tolerance. So, you know, again, what is addiction? Is tolerance and dependence, right? So they don't develop tolerance and dependence. So they do not become addicted. I'm going to just probably leave it here because we're out of time. But of course, non-pharmacological treatments are very important. There's many types. I include some tips for parents. Important also to work with schools. Dr. Fadi highlighted that. Very, very important. Some of the accommodations. Some of them are incredibly easy, like preferential seating, like having a child sit up front when they have ADHD. It does not require any resources really, just requires awareness. And that's important. But there are many things teachers could do to help these children, including some resources, including some in Arabic, resources for parents, books, some acknowledgements. Some of the slides you saw from the YECAPAP textbook is free and available online, by the way, a wonderful resource if you're ever interested to learn or teach about child mental health. They have PowerPoint presentations, everything's for free. You just download it from the website. Some of my colleagues. And also I want to mention very quickly as we end, the International Association of Child, Adolescent, Psychiatry, and Allied Professions is holding for the first time in its history. So this organization was founded in 1938. So we're getting to the 100-year anniversary in about 20 years. The first time ever the conference is going to be in an Arab country is here in Dubai at the end of this year. So I really invite you all to join us. It's going to be really a wonderful opportunity. So I hope to see many of you there. And I leave my email here, and definitely welcome to answer any questions now if you have time, or communicate with me directly if you have any questions. Thank you all so much for your attention.